We are live.
Yeah, thank you. Thank you, every one of you. So it's a good evening to all of you. It's my pleasure to welcome you all for this evening, the API-ICP postgraduate training program, virtual program. For this week, we have faculties from Department of Medicine of PSG IMSR, Dr. Velammal, Associate Professor of Medicine. And we have consultant physician and emergency department of PSG IMSR. Dr. Manisundar is there. And we have emergency department physician from SMF Hospital, Annur, Dr. Sadish Babu is there. And we have Dr. Sendil Kumar is going to join soon. He's director of Money and Medical Center, Erode, and is also president of Asia Oceanic Association of Clinical Toxicology. He's going to join soon. And we have the postgraduate department of medicine, PSG IMSR, Dr. Shiba is joining. And welcome you all for this. And we are going to discuss two important practical topics for this evening. First is going to be on, I think, paraquat poisoning or snake bite. And second one is going to be on paraquat poisoning. I request the faculties and the postgraduate to take it forward and start presenting and discuss this case. Over to the faculties and postgraduate. Thank you. Dr. Shiva can start presenting. Dr. Velammal, Dr. Manisundar, and Dr. Sadish Babu can just start discussing. Sindhil will join soon, maybe 15 minutes from now.
Yes, sir. Thanks.
Okay, sir.
Good evening, everyone. So I'll be discussing topic on snake bite paraquat poisoning. Coming to the first topic, snake bite. This is a case of 73-year-old male patient. He's a farmer from Kuchipalayam, Karur. He has no known comorbidities. Informant is the son. So he was brought to our our EMD with the alleged history of snake bite on his foot toe of his left foot while working in his farm on 29th April at around 9:45 a.m. at Kuchipalayam, Karur. Patient was initially taken to outside hospital at around 10:15 a.m. and 30 vials of anti-snake venom was administered in the outside hospital. But they gave us no medical records of the same. So patient came to our EMD at 12:50 a.m. The next day, that is on 30th April, for further management. And after giving a first aid and such as TT injections, we also gave 10 vials of anti-snake venom was administered in our EMD. Patient basically complained of left lower limb swelling since 1 day, which is extending till below the level of ankle, which is non-fitting in nature, associated with severe localized pain. So there was no history of bleeding manifestation, no history of fever, no history of breathlessness, no history of chest pain or palpitation, no history of nausea, vomiting, or abdominal pain, no history of loss of consciousness or weakness of any limbs, and no history of drooping of eyelids or double vision. Coming to past history, he's not a known case of type 2 DM or systemic hypertension or bronchial asthma or any seizure disorder or heart disease or thyroid disorder or tuberculosis or any psychiatric illness in the past. He follows a non-vegetarian diet. He has a normal bowel and bladder habits. He has normal appetite and normal sleep habits. So can I move on further?
Shiba, you are telling that in the EMD some 10 vials in PSG, 10 vials were given, no? So yes. What was the indication? Why was it? What were the tests done? And what was the indication for the ASV administration? That you have not mentioned, right?
Ma'am, one indication was he had a localized left lower limb swelling.
Okay.
And when he, I guess I forgot to mention that when he presented, he had a oliguria Along with that, he had a brown colored urine. When we received him, he had a brown colored urine along with oliguria. So, and localized limb swelling also was there on left leg.
Localized limb swelling at the site of bite. That is what you were telling?
It was till the level of ankle, which was progressing.
So what are the indications for ASV administration?
Ma'am, there is it's based on systemic envenomation and it's based on local envenomation.
Very good, very good, very good. Yes. What
So,
other?
so if it is systemic envenomation, we look for any epistasis, like clinical, like epistasis or gum bleeding, bruising, bleeding from the venipuncture sites and all, ma'am. And
Yeah. So evidence of coagulopathy, right?
Yes,
Is there evidence of coagulopathy?
yes,
Right. Okay.
A whole blood clotting time, if it is more than 20. So these are all evidence of coagulopathy.
Very good.
We look for any neurotoxic signs, like ptosis, diplopia, or respiratory muscle paralysis, or limb weakness, or any cardiovascular abnormalities such as hypertension, tachycardia, signs, any arrhythmias or anything.
Okay.
Then we look for any acute kidney injury, as in this patient, oliguria or rising blood creatinine or urea.
Yes.
Or any
why is this patient having black? You told he's having dark colored, means what
brown
was the what is the color?
brown colored urine we observed.
Okay. What is the reason for that?
Ma'am, it could be because of rhabdomyolysis or acute interstitial ATN, acute tuberous necrosis or something.
So will that cause color change of the urine? Acute tubular necrosis can result in acute kidney injury and renal failure. What is the reason for the change in color of the urine?
Myoglobin.
Either it is hemoglobinuria, right?
Yeah,
It is right. You must have seen. What is the other condition where you have common clinical condition where you have hemoglobinuria? One infection, can you say?
Right? Malaria.
Yes.
Malaria is.
Check. Then.
And
that was cerebral malaria, right? Cerebral malaria. Black water fever, we call it a severe malaria, right? Okay. So we were talking about the indications for ASV. You listed the causes for one is the local systemic envenomation you are telling now. Okay. What about the
local?
Yeah.
Local envenoming signs such as swollen digits following a bite, or rapidly extending swelling beyond the wrist, and tender lymph nodes.
Yes. Enlarged tender lymphadenopathy. Okay.
And any bitten limb, any bitten limb swollen, like half of the bitten limb is swollen within
more than half of that. Yes. Okay. Sir, Dr. Satish Babu, Dr. Manisundar, any from the history, any
good
would like to add?
Good evening, Shiva. This is Dr. Satish.
Yes, sir, please.
Usually, since I am come from a periphery setup rural area,
Yes.
I used to usually most of the times patient attenders brings the snake.
Snake, yeah, right.
How important is for Shiba? How important to know that what snake is that, or it is compulsory to bring the snake, or it is helpful to you in any other way, or it is useful in starting ASV?
So it is important because to know whether it is
useful in starting ASV.
Yes, sir.
Yeah. How it is useful?
We know how much, like for example, if it is hemotoxic or hemotoxic or neurotoxic nature. If it is cobra or wrestles, we have to give like 10 vials. If it is crate or scared viper, we have to give 5 vials. So knowing the basically what sort of like how much vial should be administered and all.
It is definitely, it may be useful because by knowing the whether it is a cobra or a viper, we can come to a kind of conclusion whether it is a hemotoxic or it is a nephrotoxic or it is neurotoxic or any other toxic. What my point is here is it is not necessary always that if you don't know what snake is that, it's well and good, because your ASV initiating ASV doesn't depend on what kind of snake it has bite. It is purely depend on the clinical symptoms. So it is because many of times in rural setups, doctors used to say, "Do you have the snake?" Or attenders are very much interested in bringing the snake. My point here is like, if it is not necessary, you should see the snake. And to initiate ASV, the whatever snake is not needed. It is only a clinical symptoms are required.
Yes. So your administration of ASV depends upon only the clinical evidence of envenomation.
Yes.
Yeah, either it is systemic or local. It doesn't warrant the identification of the snake. Why? Any other reason apart from what sir had told? See, most of the time it might be a venomous snake, like a cobra or a kite. It might have bitten, and you are seeing a fang mark. Even the poisonous snake will not inject the venom at all time. It might be a dry bite also. So in that case, if you don't have any clinical evidence of envenomation, then there is no point in giving ASV because it has its own risks of administration. Like you can have a lot of anaphylactic reactions, and it is a very rare commodity, right? It is not available everywhere. So you have to judiciously use whatever ASV is available. So unless and otherwise, there is, even though the poisonous snake, the patient attender or whatever, whoever is telling that it is a poisonous snake which has bitten the person, but if you are not seeing any clinical signs at the time of admission or on serial monitoring, if you do not find any clinical evidence of local or systemic envenomation, then it does not warrant an ASV administration, right?
Yes, ma'am.
And also, that another thing is not all snakes are poisonous, right? Most of the time it might be a non-venomous snake which is biting, right? So these are the two reasons why the identification of the snake doesn't matter much.
Okay. Yes, ma'am.
Okay. So how will you, what are the, we were talking about hemotoxicity, neurotoxicity, all those toxicity we're telling, no? So what are the common snakes which are available, which are seen in India, known to bite, and, do you have any idea about it?
Yes, ma'am. There are three main.
What are the big five?
Yes, ma'am. There are three main classification for venomous snakes: Viperidae, Hydrophidae, and Elapidae. And the big four is basically the spectacled cobra, Russell's viper, saw-scaled viper, and common kite.
Okay. The other one.
There are also other poisonous snakes such as humnose viper, banded kite, and king cobra, and also snake.
Okay. So what is the importance of this king cobra, like not that humnose pitch viper? What is the problem with it? What does our ASV normally contain?
No ASV, no ASV. We don't need to give ASV. We don't
for humnose.
We don't have ASV. ASV doesn't cover humnose.
ASV does not contain. It is a polyvalent one, but it contains only the major four, but it does not cover the humnose. That is why the renal failure, since the venom is not neutralized, there are more chances of these patients developing renal failure, and it will be persistent also.
Yes, ma'am.
Okay, ma. Okay. Then any other history you would like to ask apart from whatever history you have listed? You have talked about bleeding manifestations, and then local features also you have told. Apart from that, swelling, any other thing they can have? What are the other local manifestations? Blistering, right? No, any blisters
Yes, ma'am. Yes, ma'am.
in tissue necrosis. Okay. Then cardiovascular symptoms you have asked and neurological symptoms you have asked. Apart from that, the first slide you have written that the patient had received first aid in an outside hospital, right?
Yes, ma'am.
There 30 vials was administered. So what was the indication there? Did you get any information about that? Like why was it administered?
They didn't give us any proper medical records.
No records are available. So okay. So what is the most important thing as an in a snake bite management? ASV and all is there, but before that, before reaching the hospital, what are the measures to be taken?
Ma'am, that right criteria, ma'am.
Okay.
Reassurance of the victim.
Is it only right or carry no right?
Yes, ma'am.
Carry no right.
Carry, yes, ma'am. Carry no right. So
What is
basically, reassure the victim, and then we immobilize the injured limb. Then we get to the nearest hospital as quick as possible and tell the doctor about the symptoms. We avoid all traditional methods such as local incision, oral suction.
So that is for no. So first, what does that carry? Carry, what does that mean? Carry means we should not allow the patient to walk or run, because most of the time what happens after a bite, we tend to run. We will be having a lot of fear and we tend to run, right?
Yes, ma'am.
So the patient should not be made to walk at all. You should only carry the patient.
Okay.
Why it is like that?
It can go. The venom can go into mobilization.
It again causes catecholamine surge. No, when you have that fear, it increases the risk of yeah. So you need to carry the patient. 1, 2. No. What does that mean? What does that mean? What are the no's? You should remember.
Nose.
No tight tourniquet. Okay. No pressure bandage. No cutting. All those things, right? So
let the shock is one.
Yeah. Then whatever you have told, right? Yeah. Right is for reassurance. You have to reassure. Not all bites are poisonous. All those things you need to tell the patient so that he'll not have unnecessary fear. I for immobilization. So how will you immobilize? How will you immobilize? Most common site of bite is?
On the ankle.
Mostly in the feet, right? Legs only. Yeah. How are you going to immobilize?
With a splint, if it is splint or a sling.
Sling?
Splint or a sling.
Splint may not be available, or a simple rod you can use. And what do you have to do?
We use we use a bandage, and from the lower part we go upwards, and we cover the portion of the bite, and we don't tie it as hard. Like we should not tie it as hard.
Okay. Keep that rod or whatever it is behind that bitten limb, and you cover it with a crepe bandage if available, or whatever cloth, ideally crepe bandage from above downwards, covering that bite and thereby immobilizing it. But the thing is, it should not be too tight. Okay. It should allow at least one finger. It is just enough to occlude the lymphatics. You understand? Because the venom is reaching the circulation through the lymphatics. You should not be giving too much of pressure so that your vascular supply should not be occluded. So just your fingers should be able to, you should be able to keep it beneath the bandage and the bitten limb.
Yes, ma'am.
Okay, so that is for reassurance, R for reassurance, I for immobilization, GH for get to the hospital,
and
where the ASV is available. Get to the hospital where ASV is available. Okay, you should not waste time, taking the patient here and there, and because again, this is very important. You have to give the ASV as early as possible, because it has its own implications in the prognosis. Isn't it? Yeah. Yes. And T for tell about the symptoms and signs. Yeah. Whether the patient has developed any bleeding. Where is the most common bleeding to occur from? If at all, if the patient is bitten by a hemotoxic snake, what are the common sites where the bleeding can happen? At the bitten site of
At the
IC.
site. Yes, ma'am.
Or after reaching the hospital, suppose if you are securing an IV line at the injection site or where you are drawing the blood, there will be bleeding. Apart from that, you can have subconjunctival hemorrhage, right? You can
Yes.
have all those things. Yeah.
Okay.
Okay. So that is so carry no right. So that is the first line of management before reaching the hospital. After reaching the hospital, you do all these things. Okay.
Yes, ma'am.
Yes. What is happening to this patient? What was the examination findings?
On examination, patient was
But,
cooperative.
any past significance in past history, any medical past history importance is there in regarding this
Snake.
snake?
Sir is asking, is there any past history which can be taken a significant one?
Or any medicines patient is on?
If it is a coagulative disorder or something, if he has a coagulation disorder.
Yeah, it's very important that a patient is whether he is a cardiac patient, he is already on antiplatelets. So this is quite important. If already patients on clopidogrel, ecosprin, all antiplatelets, definitely if it is a hemotoxic, you have to keep in mind that apart from ASV, there is also a need for plasma, blood transfusion is also may be needed. So this becomes very significant, this medical past history.
Yes, sir. Yes, sir.
Yes, please go ahead.
Yes, sir. So on examination, patient is conscious, cooperative, oriented to time, place, and person. There was no pallor, icterus, sinuses, clubbing, or lymphadenopathy. There was left non-fitting pedal edema extending to the level of angle. There was no petechiae, ecchymosis, or epistasis was seen. Coming to vitals, pulse rate was 110 per minute. It was regular. BP was 120/80, measured in the right arm in sitting position. Respiratory rate was 24 per minute. Abdominal thoracic type. No usage of accessory muscle of respiration. He was febrile, and SpO2 was 98% in room air. JVP was not elevated. Single breath count was more than 30 per minute. Coming to systemic examination, serious S1, S2 was present, no murmur. Respiratory system, bilateral air entry, no added sounds. Per abdomen, soft, no organomegaly or bowel sounds was heard. Central nervous system, GCS was 15/15. He had no doses, extraocular movements were full. Bilateral eyes were 2.5 mm, externally reactive to light. Gag reflex was present. He moves all four limbs. Power was 5/5 in all four limbs. Tone was normal in all four limbs. Sensory examination was normal. Bilateral plantar was flexor. Local examination reveals swelling of the left foot till the level of ankle, and fan marks. 2 fan marks were seen on the left foot, left toe of the left toe of the left foot. Tenderness and redness were seen, and dorsalis purus could not be felt due to edema.
Okay. So what are the focused examination things which you have to do? So you have in a patient who is presenting to you with a snake bite. Focused examination, 1, 2, 3, 4, 5.
First of all, we'll have to assess the neurological status, ma'am.
So as usual, it is airway, breathing, and circulation, right?
Yes, ma'am. Yes, ma'am. Airway circulation.
Because why? Suppose you why that is important?
Airway, if for example, if airway is compromised, then we'll have to give an intubation, endotracheal intubation.
Okay. In what case it can happen?
In neurotoxic.
Okay. So it can cause how it causes airway compromise? How a neurotoxic? By
respiratory paralysis caused by respiratory muscle paralysis, ma'am.
Respiratory muscle paralysis. Apart from that, you can also have bulbar
Bulbar
analysis, right? You can have pooling of secretions, all those things, right? Okay. So airway, you have to see, make sure that the airway is patent and the patient is breathing normally and the saturation is normal. So in this patient, everything was fine, right? He was conscious, he was oriented, his airway was adequate, and his respiratory rate alone was high, right?
Yes, ma'am. Because of
Okay, but saturation was normal and there was no cyanosis. Okay. Circulation.
Circulation.
Patient is having
Hypotension. Ma'am, circulation was normal.
tachycardia. He's having tachycardia, right? How will you attribute now? Maybe he's anxious or febrile. He's febrile. He's very anxious because BP is normal now, isn't it? This is without support only, no?
Without support, ma'am.
Okay. Okay, fine. So as in any other case, you assess the airway, you assess the breathing and circulation and make sure everything is fine. Okay, his respiration status and cardiovascular status, hemodynamic step, he is stable. You make sure that it is happening. And then what else you have written? Another important parameter, what you have to check is single breath count. So what is single breath count? How will you do that? What is the importance of single breath count in a snake bite?
We ask the patient to take deep breath.
Okay.
Ask him to count from 1 to 30. If it is more than 30, it is normal. In
a single breath, okay, without taking any further breath, after a deep inspiratory effort, he should start counting from 1.
It also tells us about the bedside vital capacity.
Okay, it tells us about the respiratory reserve. So is a single breath, if you do once single breath count, is that enough? How are you going to do it? If the on presentation the single breath count, if it is more than 30, so what you have to do later? How are you going to monitor then?
For the first 2 hours, we repeat every 15 minutes.
Yeah, that is the most important. So you have to do a serial single breath count to analyze whether the patient can go in for impending respiratory failure, right? So initially now he's counting up to 30, and after 15 or 30 minutes he's able to count only 20, and later it is dropping down to 15. That means he's going in for
respiratory
paralysis, isn't it? So you may have to intubate or whatever, do adequate necessary steps to tackle that, isn't it? So what are the other bedside clinical tests what you can do to check for respiratory paralysis or impending respiratory neurological involvement?
We'll ask him to say a sentence, long sentence.
That I'm not sure. Sir, is that so? Okay, any other parameter apart from single breath count?
I didn't get that last point.
She was telling ability to talk in sentences. I'm not sure about that.
Not sure, ma'am. Probably
usually in acute asthma, we can take that as a bedside test for ability to talk in sentences.
Yes, ma'am.
I'm not sure about it in snake bite. Single breath count, definitely. Serial single breath count. Any other bedside evaluation you can do? Often we ask the patient ability to lift the
neck holding.
Yeah, that is one thing. And then ability to maintain the upward gaze. So these are all some of the, or FEV1 also we can do, bedside post expiratory volume in 1 second. That also can be done. Okay, so airway, breathing, circulation, then single breath count. Then what else? What other focused examination you will do? Local examination, isn't it? In local examination, whatever you have seen. So swelling. So what important in the emergency room? What you will look for swelling? You look for blisters. You had looked for Frank marks. All those things. Then distal vascularity also you are checking. Apart from that, how will you know the swelling is rapidly increasing? Always we need to measure. So the time of
limb.
yeah, you have to measure the limb. What is the circumference, right? So that will help you to serially monitor. So in snake bite, the most important thing is not only the presentation findings, we need to monitor closely.
Yes, ma'am.
So you need to measure the limb circumference also. Then only you will know. Now, at the time of presentation, it is 25 centimeter. In another half an hour, it is going to be 30 or 40 centimeter means then that is an indication for ASV, right?
Yes, ma'am.
Yeah. And then one more local examination finding what you have not mentioned is regional lymphadenopathy.
Yes, ma'am.
That is again an indication for ASV, right?
Yes, ma'am.
Okay. Okay. So local examination, these are all the things which you have to look for. Then what else? Systemic.
Systemic, ma'am, is
Whatever, yeah, you need to see, you have written the CNS findings, konjo, it was, you have written cranial findings and then the motor power, then tone. I think it is not in the order. I think you have to say it in the order, right?
Yes, ma'am.
Yeah. Okay, ma. Then what else? So most important thing is, what are the neurological manifestations you can have?
Those.
Why there is ptosis and external ophthalmoplegia, right? These are the most important, most common findings which we see in neurotoxic snakes.
Neurotoxic snake bites.
Why is it like that? How does it happen?
Because, ma'am, this neurotoxins they act as postsynaptic and they bind to acetylcholine at the neuromuscular junction.
They bind with the
Acetylcholine at the neuromuscular junction.
they interact with the receptors, right? And they, as a result of which it prevents the interaction of acetylcholine with the receptors, resulting in neuromuscular blocking. Okay. Then why specifically this ptosis and external ocular muscles alone are involved? Is it like that, or all neuromuscular junction blockade happens? So the postsynaptic thing, it is more, the fibers are more in the sphincter pupillae as well as in the levator palpebrae superioris. So they are the most common sites. The blockade happens first. And so we have the initial manifestations of ptosis and impaired extraocular movements. Later, you can have involvement of all neuromuscular junction thing resulting in the blockade of transmission. And you can have, the most important finding is, what is the paralysis? What is the pattern of paralysis in snake bite?
Descending paralysis.
Descending paralysis. Very good. So you can have descending paralysis. So it will result in acute flaccid paralysis. Right. Right. What is the close DD for descending paralysis apart from for snake bite? Botulinism. Very good. Very good. Okay. Okay. Yes. So apart from CNS thing, you need to see the ptosis, extraocular movement, gag reflex, right? Palatal weakness, then power of the limbs, all those things we need to check. And in the CVS, what is the importance of CVS examination?
Ma'am, we check for any tachycardia, shock, or hypotension.
So why there is, how there is hypotension or shock? How, what is it?
Ma'am, because there is venom-induced vasodilatation, which can cause, which can also cause
myocarditis. One is myocarditis, other one is due to bleeding. Also, they can develop hypotension and shock, right? DIC, with the development of DIC and bleeding, they'll develop hypotension. Another thing is a lot of cardiac arrhythmias. So you need to do an ECG.
Yes,
so pulse examination, the regularity, all those things. Pulse examination also, whatever you have told, it's not a complete examination.
Yes, ma'am.
Okay, ma. Okay. So what is your diagnosis?
Ma'am, at the end of the examination, it looks like a snake bite, probably a vascular toxic snake with systemic envenomation.
Why systemic envenomation?
Because ma'am, I forgot to mention that initially he had oliguria in outside hospital. Along with that, he developed a brown colored urine. So
Okay.
we received him we received him when we received him, we were still having oliguria, and also there was brown colored urine also. Now. Along with that, he had systemic local inflammation signs such as left lower limb cellular, left lower limb edema. So it could be a tubular nephritis.
Okay. What are the local complications he can develop?
Locally, you can develop gangrene, necrosis. We can go into cellulitis.
Cellulitis.
Yes, ma'am.
Then compartment syndrome, right? Compartment syndrome.
Yes, compartment syndrome.
Okay. So these are the local complications apart from the neurological and hematological cardiovascular compromise.
Ma'am,
Yes.
Dr. Sandil here. I just
Sir,
want to add
good
one
evening,
thing,
sir.
ma'am.
Yes, sir. Yes, sir.
Good evening. I joined before itself, ma'am.
Oh, yes,
Two
sir.
things
Welcome,
I want to, two things I just want to include, ma'am.
Yes,
One
sir.
is sign of blisters.
Yeah, yeah.
Most of the time, there will not be having any ascending swelling at the time when the patient present to emergency room, but the blisters will be there. So the blister itself an marker for developing compartment syndrome. One. Most of the emergency rooms are now equipped with the ultrasound.
Yeah.
So when we started training, we used to put a needle and we measure the pressures of compartment. And in snake bite, most of the time it will act on the fascia because it is just the venom goes like an intramuscular injection. So it carries through the lymphatics. So most of the time the lymphatics will be over the fascia and fascia will be necrosed. So there is no tight compartment will be there, though there is a swelling. So whenever you put a needle, it gives a false sense the compartment is not compartment pressure is not raised. So now because of the advent of ultrasound, what we can do is we can do a target artery pressure. If it is bite in the lower limb, we can do a posterior tibial target artery pressure. If the target artery pressures is more than 40, then it indicates that the patient is having a compartment syndrome. So we did a comparative study by putting a needle and we measured. At the same time, we also did a ultrasound. And we found that ultrasound is more sensitive and specific for the compartment syndrome rather than putting a needle.
Okay, sir. Okay, okay.
So these are the two things I want to inform
Thank you,
here.
sir. Thank you, sir.
Thank you.
So, apart from what sir had told, Shiba, any other point of care tests which are available now to detect coagulopathy? The routine test what we do bedside is to detect
20-minute whole blood clotting time.
you know how to do the whole blood clotting time, right? So what is the problem with the whole blood clotting time? What are the advantages or what are the disadvantages? Are there any other tests which are available, point of care tests which are available?
Advantages like it's easy to perform. It's a bedside test.
What is it, ma? Sorry.
The bedside test easy to perform.
One is advantages is it is easily available everywhere and simple to perform. Okay.
But
what is the problem?
Not sure, ma'am.
If the test tube is not clean, it may interact with the result, right? One thing it has, right? And then, so at least 30 to 50% of the clotting factors should be depleted to get a positive result.
Yes, ma'am.
Okay. So these are some of the problems. But what are the newer tests which are available? Point of care tests. Point of care means the result should be available immediately. So there are certain hospitals where you have point of care PTINR testing actually.
PTINR is
So, or we can send it to the PTINR. The reliability is even more. Even if there is a 10% reduction, 10 to 20% reduction in the clotting factors, it is going to be prolonged. So you're able to pick up the coagulopathy earlier.
Yes, ma'am.
Okay, so that is the advantages and disadvantages with whole blood clotting time and PTINR testing.
Another one important thing is which container we are using.
Yeah.
I trained in a government hospital, ma'am. I used to use with ceftriaxone bottle. After
Which will be available after cleaning.
Yes,
Yeah,
yes,
that's what. Yes, sir.
So from the WHO.
What will be the problem when you use a cleaned thing and do it? Most of the time after the patient comes only, we will clean the ceftriaxone bottle, right? Yeah.
So there is a comparative analysis was done by my colleague from Sri Lanka, where they did in a plastic tube, test tube, and this bottle.
Okay, sir.
And on the other hand, they did it with PTINR and APTT, ma'am.
Okay.
They found that all these three delays the care.
Yeah.
First test is coming as a normal or a near normal.
Near normal.
And even PT is not giving more sensitivity.
Okay.
APTT, that is the first thing to get changed.
Prolonged. Okay.
And they did in 3,000 patients, ma'am, and they found that APTT is more sensitive than your 20 minutes whole blood time because of the. This is in a rural area where the APTT is not available.
Not available.
So, still, we are relying on
whole blood clotting.
20 minutes whole blood time. Another one important thing when you point out about the point of care. We are in the era of point of care. Vitamin, the PT, APTT also can be measured. No?
Yeah. PT, point of care tests are, kits are available.
Point of care test is available.
Yeah.
And, I have burnt my, I have a personal experience. I burnt my finger. One doctor's father had a bike. He was running to the home, had a fall, had a lip injury and tongue injury.
Oh.
So immediately the patient was taken to the hospital.
Okay.
Because of the doctor's father, they did point of care. So point of care PT was normal. But there was a diffuse ooze was there. So after 30 minutes, again they repeated. Like that 6 times it was repeated in the interval of 30 minutes to 1 hour. 3 hours they were waiting for this. And there was a continuous ooze was there. But it was not, the bleeding was not such that it is from the injury. It was a diffuse ooze was there.
Okay.
But the PT, APTT in the point of care was normal.
Okay.
Then they called me in the midnight, 12:30. I went and we sent the lab, and lab it came as prolonged. Then we started on ASV. Then we inquired with the company people. They told that this is designed only to monitor vitamin K antagonist in the wall replacement patients or the patients with venous problems.
So it depends upon the kit what we are getting also.
This machine will show value up to 5. After, if it is more than 5 INR, this will automatically go as a default, it will go to normal.
Oh, fine. So it will be false negative then, right?
Yeah, ma'am. This is important caveat for using this point of care, ma'am.
Always clinical examination is the gold standard.
Yes, ma'am. With both the patient has to show clinical environment, science of environment as well as supported by the laboratory. Then we can proceed with anti-snake venom.
Okay, sir. Thank you, sir.
Another one biomarker we are using is NGAL, ma'am. Now we are using.
What is that, sir?
NGAL, ma'am. NGAL.
Okay.
This neutrophil gelatinase associated lipocarpine.
Okay.
Commonly used in nephrology for contrast-induced nephropathy and all, ma'am. So we started using in snake bite for predicting whether this patient is going for acute kidney injury following snake bite, or this patient may land with hemodialysis.
Okay.
So based on this cutoff value, this works very good, ma'am. So that on the time of admission itself, we can prognosticate the patient.
Okay.
From the bite time to 1 hour crosses, if the NGAL value is more than 250 and less than 500, this patient is more prone developing acute kidney injury. So nephroprotective support is sufficient. If it is 600, 650 like that, this patient will definitely need a hemodialysis.
Okay. Okay, sir. Thank you for
Thank you, ma'am. Thank you.
Hello, madam.
yes.
Greetings, Sendil sir. Like to add a point, madam. When dealing with the ABC, along with the ABC, at the side, we have to resistate the patient whenever we deal with the ABC. In circulation, regarding this patient, as there was oliguria, there's a decreased urine output and color
Right.
also high color.
Yes.
So it needs to be intervened at that moment before going to the investigation or before going to the definitely treatment. This part comes under ABC. So that purpose, it is always better to do IVC at that moment, whether you have to give fluid or you have to think of hemodialysis. So in that background, in circulation, I want to add IVC also as a part of ABC. And also BTCT is to be added in circulation in regarding the snake bite patients.
Okay. Shubha,
Sorry
the
to
fluids were
interrupt.
started.
Actually,
Fluids were started. What was the initial man? Sir was asking, no. So what did you do for that thing, for the oliguria part and?
We gave fluid resuscitation, ma'am, along with Lasix also we gave.
Why Lasix?
Lasix because we were thinking of a pre-renal.
No, for pre-renal, why Lasix?
Uh,
Pre-renal means already volume depleted, no?
but we gave fluid resuscitation, ma'am. Yes, ma'am. And the serial RFT was done, and basically within 2 days, his output improved. And we mentioned.
So what are the what are the various ways how kidney is affected in a patient with a snake bite? In this case, you told it is pre-renal, right?
Yes, ma'am. It looked like pre-renal. We gave fluids and it improved, ma'am.
Okay. What are the other ways? What are the other?
Ma'am, other is hemoglobin hemoglobinuria.
So due to intravascular hemolysis, right? Okay.
Myoglobinuria.
Okay, myoglobinuria.
Acute tubular necrosis. Interstitial nephritis.
Okay.
Yes,
Okay. So what did you do later after this? Like you have done the.
I'll be mentioning in the course in the hospital.
What was our yeah, you can proceed. Yes. What are the investigations you sent from the EMD?
Initially, when he arrived on third week, we saw that his total counts, there was a leukocytosis, and his neutrophil was also elevated. When we monitored serially, it was in a decreasing trend. But but in between, on the 4th of May, there was thrombocytopenia, and LFT was normal. TT was mildly elevated, 11.3. APTT was also borderline high. CPK was normal. Urea initially was 80 on admission, and creatinine was 2.42. So we gave fluid resuscitation, and following which we kept in view of hemodialysis also. But patient improved further. So and along with that, his initial ABG showed metabolic acidosis. Lactates were also elevated. And urine, there was RBC of 124 cells per high power field. Myoglobinuria, myoglobin and blood was also present. Whole blood clotting time was less than 20 minutes now. Can I go further?
Yeah.
Initial chest X-ray was normal, and ECG showed a sinus tachycardia. Echo also it was concentric LVH normal LV ejection fraction. There was grade 1 LV as well as dysfunction, no growth of pericardial effusion. Initially when he came, he had oliguria, only he passed 230 in 24 hours. So it was brown colored urine, and we gave a fluid challenge. So we repeated RFT also, and it was also an improving trend. Repeat whole blood time was also less than 20 minutes. In view of diffuse edema of his left lower limb, where we could not feel, where we could not even feel the dorsalis pedis, we did the USG artery and venous Doppler. So it was suggestive of atherosclerotic wall calcification with intimal thickening, and no evidence of DVT was there. So from day 3, he was his vitals and vitals started improving, and we shifted into ward, and later he was discharged.
So how will you monitor a patient after you have decided based upon the systemic envenomation features? You have given ASV in the EMD, right? 10 vials you told.
Yes, ma'am.
Okay. How will you give ASV, Shiba?
Ma'am, ASV, we can we usually dilute it in 1.10 ms.
1.10 ms, is it okay?
Or in 5% dextrose IV infusion, we can give over 1 hour.
Suppose if the patient is volume overloaded, do you have to dilute it only in 500 ml?
No, ma'am. We can 100 ml, 100 ml also. Basically, dilution NSV or 5% B.
So each vial you have to dilute with 10 ml, right? It is available as freeze powder. I think liquid formulation is also available. And so the initial dose is 10 vials, right?
10 ml.
So 100 ml we'll be taking. And, the thing is, you give at least 1 ml per minute. Okay. Usually you have to give within 100 minutes, 50 to 100 minutes. That is the usual.
Okay, ma'am.
What are the things which you have to monitor? Do you have to give a test dose? Is it needed?
No, ma'am. Test dose is not recommended, ma'am.
Why?
Because patients can have local reaction also.
The test dose is not predictive, will not be predictive, because all these reactions which happen with ASV is complement mediated, whereas your test doses will be only IgE mediated, right? So it will be of no use actually. And furthermore, it is going to sensitize the patient. So the risk is
even if the patient develops allergy, we don't have any alternative.
So you have to give. What will you do, Sheba, then if suppose any allergic, what are the various reactions you can have while you have started the patient? Okay, with 1 ml per minute, and after 10 minutes, what are the things which you have to monitor? The signs
can be a patient can have allergic reaction within 10 minutes, such as itching, urticaria, angioedema, bronchospasm, anaphylactic shock. Within 1 to 2 hours, we can also develop.
We can also develop abdominal pain, vomiting, diarrhea also for reasons unknown, right? So they can have hypotension, shock, urticaria, angioedema, bronchospasm, these things. So what will you do then?
We can give initially a low dose adrenaline, 2.5 mg subcutaneously.
2.5 mg?
Adrenaline subcutaneously.
I think it's not 2.5 mg. It is 0.3 or.
Sorry, ma'am. 0.2. Sorry.
Adrenaline is 0.5 milligram.
0.5 milligram. Yeah, 1 in
in
1000.
The lateral thigh.
Yeah, 0.5 mg.
Yeah, exactly.
How many times you can repeat?
How many times?
At the maximum of 3 times you can give. At the interval of 15 to 20 minutes.
Yes, sir. Yes, sir.
Most of the time it will settle with first dose or second dose. Before starting ASV, to avoid this, there are few centers advise giving pre-medication, but from the center where I was taught was we don't practice this steroid or antihistamines. But what we strictly follow is we have a strict hand hygiene. So most of the time, this is pyrogenic kind of
Yes.
reactions will be there. So this can be prevented by your clean hands. So that will help you in reducing your anaphylactic reactions.
Yes, sir. Yes, sir.
Ma'am was telling about the liquid form of ASP and powder form.
Yeah.
What is the difference between this and what caution you have to take when you are getting this two?
A dilution method, yeah.
From the powder, when you are, that is a lipophilicide powder. So lipolyzed powder, when you are diluting, what are the things you have to see? And when already it is in a liquid form, what you need to look for it? It is easy for us to have a liquid form, no? Why we are getting lipolyzed?
Basically, sir, it does not require cold storage.
Excellent.
Storage
Because most of the time this happens in the rural area where the cold storage cannot be kept. So the lipolyzed doesn't need any cold storage.
Yes,
Cold chain is not needed.
yes, sir.
Second one is
More expensive. It is a more expensive.
okay.
But it is more expensive, sir. And dry powder is basically we dilute it in 10 ml or 5%.
Actually, shell life.
Yes, sir.
It has a 5 years. Lipolyzed has a 5 years of shell life, whereas liquid form has 12 months.
That's
so
a
1 year
huge
only.
difference. No, that's a huge difference, especially in our country. Yeah.
In a resource limited country, so when we have this has to be immediately done, otherwise it will be expiry. So whenever you are using a liquid form, always look for the manufacturing date.
Yes.
That is one thing. Thank you.
Yes, sir. Thank you.
Madam, one more important point I'd like to add is, Dr. Shiba, how do you administer adrenaline if you are dealing with anaphylactic shock? After giving a ASV or generally any other anaphylactic shock, how do you give adrenaline?
So adrenaline intramuscularly, so initial dose of 0.5 mg.
Yeah.
No.
One in 1,000. So we give 0.5 mg as IM, sir.
Yeah, any anaphylactic shock, you have to give it through IV. It is not through subcutaneous. So it is 1:10,000 dilution, 50 microgram bolus. In other ways, you have to take 1 ampule in 10 ml of NS, dilute it and give 0.5 ml IV.
Yes, sir.
No, IV is advised only when the patient is not responding to intramuscular or the patient is going for a impending cardiac arrest or cardiac arrest. Then only we have to give IV for this anaphylaxis. Otherwise, this itself can cause coronary vasospasm and can mimic like an MI. So IV is the last resort. First, you try with the intramuscular, no subcutaneous.
Yes, sir.
Because in the shock, the perfusion will be constructed. So there is no absorption from the subcutaneous. So it is only through the intramuscular.
Yes, sir.
After giving 2 times, still the hemodynamics is not improving. Still the patient is in shock. Then you can think of giving adrenaline in the IV. It is a class 3 evidence only.
Yes, sir.
Okay. Sir, anything else, or shall we move on to the next one, sir? Paraquat.
Dr. Shibal, one last question.
Yes, sir.
Most of the times, many a times, actually, we receive a patient who have tight tourniquet around that limb.
Yes.
So when will you decide how to, to remove the tourniquet if it's very tightly, it's very tight. Yeah.
And what precautions you will take before releasing the tourniquet?
Yes, yes.
So we will first check the.
Can we just release it or?
No, sir, we can't release it because there is because once we release it, the venom will go into the circulation and the patient can collapse, sir. So we have to
Yes.
release it slowly, and we check for the limb ischemia or something. So like how is uh, the limb? We look for the peripheral pulses and also. So we can first we can give AS. Can we ASV after ASV? After giving an ASV, we can remove it slowly, sir.
So to take precautions of all the things which you have mentioned so far. You have to check the whole blood clotting time, you have to check the INR, you have to check his neurological status, you have to check his limb.
Yes, sir.
If everything you feel is normal and if you feel the envenomation is not, it's just a dry bite, you can try to, you can release it. Or you have to definitely start ASV, and it's always recommended to slowly release the
Yes, sir.
tormented.
One method is you can inflate the BP cuff.
Yes, yes.
Okay, and slowly release.
Ma'am, as per International Society of Toxinology guidelines,
Okay, sir.
we discourage the tourniquet application at all, ma'am.
At all, there is no tourniquet.
It's still,
Only creep bandage.
it's still, yes, sir. It is the pressure bandage, ma'am.
Yeah, but then we are still seeing
And
patients
now-
coming with tourniquet, sir. So how to like.
He developed a cerebral fat embolism
Oh.
because of this tourniquet.
Mm-hmm.
So we had a stormy course in ICU and then he came out. So other important thing what in our clinical day-to-day practice we advise is always start an IV line, good large bore IV line, and run the IV fluid, then you can remove it. Because the sudden gush of venom, though even if you are starting ASV and waiting for the clotting time to come, then you're starting ASV, it further hampers the vascular system there. So it is always advisable, put a large bore IV, give some bolus of fluid, then you can slowly remove it. Even there is a surge of venom enters into it, this fluid will manage that. They will not go for immediate shock or any other thing.
Yes, sir.
Can I ask the faculties a basic question?
Sir?
Hello,
Yes, sir.
am I audible? Yeah, can I ask the faculties, all the faculties a basic question? Is there a difference in the reaction to monovalent anti-snake venom and polyvalent? Because what we practice is available in India is only
Can you repeat the
polyvalent.
question, sir?
Hello.
Can you repeat, sir?
And the difference between the polyvalent ASV and monovalent ASV.
Okay, sir. So I have used both, sir.
Okay.
In India, I use polyvalent.
Yeah,
No other antivenom is available here.
correct.
In Australia, we use monovalent.
Correct. Even US
So
also you have a monovalent ASV.
Most of the time in Australia, when they come with the history of snakebite, actually, I trained in Queensland, which is a remote area. In Royal Adelaide, we do a ELISA test and we confirm it, and then we give. What is the advantage of monovalent is we are giving exact antivenom for the species which has injected the venom. So no cross reactivity will be. And the amount of venom injecting will be very low.
Okay.
Here, the Russell Viper, we advise for 30 vials, 40 vials, 50 vials.
Yeah.
There they will give only 2 to 5 vials, not more than that.
Yeah.
That is the most advantage. And here, we don't have a ELISA kit. So it is very difficult to identify and use the monovalent. And the manufacturing itself, they are giving for the big four. And from Indian Society of Toxicology and Indian Society of Toxinology, we are asking them to remove saw-scaled viper from the big four. because it is not going to cause much harm, and it is not producing significant toxicity. So removing that from the venom, anti-venom, so that the incidence of anaphylaxis will come down, sir.
Okay. Because the polyvalent might be having different antigens related to protein material, might be having more reactions than monovalent anti-snake venom. That's
Yes,
a theoretical
yes, sir.
possibilities are there. As you said, definitely the requirement is going up with polyvalent, since we have a major accessibility only for polyvalent than monovalent, because our way of approaching to identify or isolate the species is very, very remote. So we have to go for polyvalent to address the problem of snake bite. So in that case, the requirement is going to be basic units of 10 vials. That's what we practice commonly. But whereas if it's going to be identifiable reason, then it's easy for us to go for cutting down the usage of ASV. As you said correctly. So these are the two important points we have to learn. Because when you go into practice in US or Australia, where you do come across a lot of snake bites also, and you need to go for identifying the species and go for monovalent, it's less dosage is requirement, less chance of reaction. And the other side of it, less costly also. Whereas not only costly for the vial, but vial related or medicine related consequences also can be brought down. So the cost factor will also go down. Whereas if it's going to be polyvalent, what we practice, slightly higher cost, higher amount of anti-snake venom exposure. It's very important. Anybody else would like to make any other comment regarding this, or any other points to learn?
Lastly, Sheba, is there any dose difference for pregnant ladies or for children?
No, ma'am. There is no dose difference, ma'am.
So it's always going to be the
same dose of ASV in adults.
Okay.
And already the point is mentioned by Dr. Sendil and Dr. Velamal also. We have to re-challenge the patient with ASV. That's very important point. Yeah. Okay. There's no further points to discuss in this case. Can we move on to the next case, paraquat poisoning?
Yes, sir.
Yeah, please.
Yes.
Over to faculties, please. Thank you.
Coming to the next topic, paraquat poisoning. So this is a case of 27-year-old male IT company employee. He's from Coimbatore. He has no known comorbidities. He came with alleged history of consuming paraquat, unknown quantity at his residence at 8 a.m. On 30th of May. He presented to us with history of vomiting, which was 2 episodes soon after consumption, which is non-projectile, non-bilious, and not blood tinged. There was no history of breathlessness or cough, no history of chest pain or palpitation, no history of fever, no history of abdominal pain or loose stools or yellowish discoloration of eyes, no history of decreased urine output, no history of confusion or irritability, no history of seizure, no history of brain manifestations. Past history is not a known case of type 2 DM. No history of systemic hypertension, no history of bronchial asthma, no history of seizure disorder, no history of thyroid disorder, no history of tuberculosis, no history of psychiatric illness, no history of heart disease in the past. He follows a non-vegetarian diet. He normal bowel and bladder habits. He has normal appetite, and he has a reduced sleep. Can I go forward?
Yeah, you can go. Paraquat spelling is Quat. Yeah?
Yes, sorry.
Yes, ma'am.
On examination, he was conscious, cooperative, oriented to time, place, and person. He had no pallor, icterus, sinuses, clubbing, or nephropathy or infidel edema. His oral examination was normal. Pulse rate was 92 per minute. BP was 120/80, measured in the right arm in sitting position. Respiratory rate was 18 per minute. Abdominal thoracic type. No usage of accessory muscles of respiration. SpO2 was 98% in women. He was afebrile. System examination also was normal. CVS was revealed S1, S2 was there, no murmurs. Per abdomen was soft, non-tender, no organomegaly. Respiratory system, there was bilateral air entry, no added sound. CNS, no focal neurological deficit was seen.
So what did you do in the EMD?
Yes, EMD, when he presented, his counts were initially, CBC was normal initially.
No. What did you?
No, yes, ma'am. We inserted an RP, following which RP was placed, and we sent all the initial blood samples, ma'am, and the ABG was sent. The chest X-ray was taken. Should I show the investigations, ma'am?
No. What was the time interval between the intake and presentation to the hospital?
Soon he was brought immediately.
Okay. So what you are supposed to do? You put the you must have done the gastric decontamination.
Yes, ma'am. Yes, activated charcoal.
First gastric decontamination, right?
Yes, gastric lavage, activated charcoal, RT2 placement.
Okay.
Yes, ma'am.
And you need to collect the sample. That's more important, right?
Yes, ma'am. Yes, ma'am.
You need to preserve that sample. It's very, to send for toxicological analysis along with the blood and urine. If it is a paraquat poisoning, it's even more important, right?
Yes, ma'am.
And also, since patient is conscious oriented,
Yes.
you have to give a idea of how much quantity he has consumed, because totally the prognosis of this case is depends on the dose and time of the presentation, how much dose he has taken. So try to give an idea about because you can since a patient is conscious, you can ask whether he has taken how much ml, approximately how much ml, because it will give a very big idea about the prognosis. So the quantity, the time of presentation, ingestion time and the presented to hospital time is very, very important when you consider history for paraquat poisoning.
Yes, sir.
Any idea how much ml he had taken? Not sure, right?
Yes, ma'am.
He was not able to tell. What is the lethal dose?
Ma'am, lethal doses 10 ml of 20%. 20%. Usually it is available as 20% concentrate. Ma'am. So 10 ml of this 20% concentrate is lethal.
It's 20. Okay, 20 to 30 ml. I think I'm not sure.
30 ml.
30 ml, right? 20 to 30 ml.
What is given in the book or any other papers, 10 to 20% is a moderate. 10 to 30% is moderate. Anything above 30 ml is severe. But as Siva said, even 10 ml is going to be dangerous. It is going to be lethal. By book, it is given as more than 30 ml, it is severe. But even a 10 ml could be a lethal. As per experience, even 10 ml could be a lethal.
Another important thing is whether it's a freshly prepared solution or it is an old preparation. Then again, I think the lethality differs. That is also most of the time, if it is left open or it's an old pack, then again, that even though the patient had taken more, it might not be that much lethal.
Yes, ma'am. Yes, ma'am.
What is the mortality rate for paraquat?
Mortality rate.
Low mortality or high mortality?
Mortality, ma'am. High mortality.
Around 80%, right?
70, above 70%. Yes.
How does it cause?
Basically, mechanism. Basically, this concentrates in the Paraquat concentrates in the pulmonary alveolar type 1 and type 2 cells now. Basically, there is a it acts by inhibiting superperoxide dismutase, and this free radical is produced, and this results in lung damage. So this will cause and also renal failure. So basically, this could be a reason for mortality. But then the further hypoxia sets in, refractory
Causes multi-organ dysfunction, lung, heart, like liver,
high concentration.
all those with a very high blood flow. No, it is removed from the circulation and it is getting concentrated within the cells. So sometimes even the blood level may not be there, may not be found, but the urine and the kidney will eliminate it.
Yes, ma'am.
Okay. Yeah. So it causes multi-organ dysfunction. As you told, it can cause pulmonary involvement, ARDS like manifestation, or late stages.
Later stages, yes, ma'am.
Pulmonary fibrosis, right? It will set in cause.
Yes.
Liver.
Pulmonary fibrosis is one thing which is really is dangerous, which is lethal. Any other thing, multi-organ failure can be dealt and dealt. Probably when we allow to go to the stage where a pulmonary fibrosis happens, then it is almost difficult to save the patient.
Yes, sir.
So you have received the patient, you have settled the ABC, and you have inserted an RT, and you have done the gastric decontamination. Then what else you did?
Ma'am, we took for an emergency hemodialysis, ma'am, because his
how are we removing the paraquat by hemodialysis? Any other method? So when the renal failure sets in, then probably along with you may have to go for
hemofiltration.
Charcoal hemoperfusion, right? It has to be done immediately. Charcoal, when the renal function is intact. So in cases where there is renal failure also, you may have to combine both the charcoal hemoperfusion and hemodialysis. And the development of renal failure is again a bad prognostic indicator. Because, yeah. Okay. What are the other management protocols?
We can give if in case patient is in severe pain from all this oral ulcer from esophageal or abdominal because of the corrosive injury, we can give analgesics, or we can also start on any antioxidant therapy to prevent this free radical injury, but it is
there
not
is no confirming evidence.
Evidence for that one. NAC, I mean vitamin C, N-acetylcysteine, vitamin E can be started. Patient can also be started on to reduce the tissue toxicity. Patient can be started on cyclophosphamide.
For that, I think steroids. No, steroids have a role.
Yes, ma'am.
Anti-inflammatory.
Yes, dexamethasone. Basically, it's palliative care, ma'am. I don't know. We can then, if it's in a higher amount, then we'll go for palliative care. Antibiotics also can be started to prevent infections.
When there is evidence of infection, so paradigm.
Yes, ma'am. Yes, ma'am.
Okay, what up?
One thing where it is very important regarding this paraquat poison is how to use oxygen. Anything you want to add up, Dr. Shiba, regarding the usage of oxygen?
So usually we'll wait and watch unless the patient develops SpO2 levels or hypoxia. If it goes below 90, only we'll start minimal oxygen, sir.
Why you have to avoid oxygen?
Because there is because of the redox. I mean, This redox, both the oxygen that we are supplying along with the free radical, both can cause increased injury to the lungs.
Generation of reactive oxygen species, which is causing injury, understood. But one thing is, whenever it is necessary, whenever you see a significant hypoxia, we always start oxygen, and if needed, you have to protect the airway, intubate, you have to ventilate. The ventilation is again probably a hallmark of the treatment, apart from along with charcoal hemoperfusion, because the initial phase of the lungs is what we are dealing is pneumonitis or ARDS. For that, ventilation is very much needed. You have any other thing can be used in the pre-hospital setup before coming to the hospital? Any other thing will help? If someone is giving a call that we are getting a Paraquat patient to your hospital from home, any advice you will give through the phone?
So charcoal, we can ask for activated charcoal.
It is very much
You can-
oriented. You can ask them to take you. Yeah, have you heard of Father Muller's or
Yes, sir.
that actually what is that Father Muller?
Multani mitti.
Yeah.
Fuller's Earth, sir. Fuller's Earth.
Sorry, Fuller's.
Bentomite.
Yeah.
Bentomite.
Yeah, that is one thing, and you can ask to ingest before coming to the hospital. Yeah, please go ahead.
So initially, when he came to EMD, CBC was normal. Later, there was leukocytosis. Along with that, LFT was normal. Only towards the end, SGOT was mildly elevated. Even total proteins also was towards the end was in decreasing trend. Initially, his urea and creatinine was normal, but towards during the course in the hospital, urea and creatinine there was elevation was seen, sir. And ABG wise also initially there was metabolic acidosis, and with mild lactate levels were also raised. Even complete was normal. Initial X-ray was normal, and when we repeated after 3 days, it showed bilateral these reticular opacities were seen. And
The second X-ray, I see a tube is inserted. So that what was the reason to intubate, and whether what was the indication to intubate and ventilate? That part was not discussed.
Yes, sir. Towards the day 5th, he started developing severe hypoxia, sir. He was his respiratory dropped below 85, sir. And his vitals, and he was shifted immediately to NICU, and we intubated him for the same, sir. In view of worsening hypoxia, I mean, as his respiratory was dropping, sir. We have we have even started in. Yes, sir.
So what is happening to the patient? So the we all know that the initial day 1, 2, 3, lung tissues or alveoli part is affected, and we have to deal with pneumonitis or ARDS. So we are in that phase. Yeah. Yeah. Next. Yeah. Yeah. Go forward. Yeah. Go next slide.
It was day 4, and they revealed the multiple large areas of consolidated ground glass density with interlobular septal thickening in bilateral lung field. So we saw minimal pleural effusion, which is right more than left. You can see here consolidation and septal thickening is seen. So patient initially was in our hospital, was given a stomach wash and activated charcoal. RT tube was placed, was taken for emergency hemodialysis. Following which, patient had multiple episodes of vomiting and GI endoscopy was done, which showed esophageal grade 2B injury and stomach grade 1 injury. So by the 4th day, he developed difficulty in breathing and desaturation. So he was immediately shifted to MIC, and he was also given a dose of methylprednisolone for 500 mg for 3 days, and cyclophosphamide was also given. And he was for which he was intubated. After which he was intubated in MIC. But patient attenders were not willing for further management, and patient will be.
Doctor, can you justify why was the patient not admitted in ICU directly and was kept in ward initially, though he was stable? Okay, just for a matter of discussion, if I was in your place, I would have kept the patient in ICU, though he was stable.
So he was initially in since after the dialysis part, sir. After dialysis, since his vitals were stable, he shifted into.
Can you show me the EVG?
Yes.
This was taken in emergency on the day of presentation.
Emergency, sir.
Okay, this was already showing hypoxia here.
Yes, sir. Yes, sir. But he was maintaining illness, sir.
The thing is, Paraquat has a very high mortality rate. We cannot predict when the patient will start deteriorating. They can, I mean, even mild changes in like decreased urine output or desaturation, it needs continuous monitoring for this patient, so that prompt action could have been taken rather than having him in an unmonitored area.
Yes, sir. Yes, sir. Well, initially, he was in ICU. So basically, the hemodialysis was done, and the next day he was in ICU.
He was directly admitted in ICU.
For hemodialysis, he was done, and he was in ICU. And for 2 days, he was there, and then he went back. Then he started desaturation, then again shifted back to.
Fine. Okay. Next.
This is basically, and we're talking about Paraquat and Paraquat. Can I go ahead with that, sir?
Before proceeding to this, just like to ask the faculty, is there any poisoning of different chemical poisoning of this nature? We have to be more alert, alert that the initial presentation, initial days of the hospitalization might be looking very normal. From the 3rd day or 2nd day onwards, they might get worsening. It is basically the question is raised for the benefit of the postgraduates to make them to understand few poisoning. We have to be very, very alert. Even 3rd day, 4th day, because sometimes the discussion is happening with the family members. After 1st day, 2nd day, patient looks normal. Initial reports are a bit normal. They started discussing with the family members regarding discharge. So probably I would say it's not premature. So premature to discuss about, not prematurity of these people, but it's premature to discuss about the discharge. So I like to listen from the faculties regarding the few poisoning where we have to be more alert regarding the late development of complications or the problem development.
And one thing is, Paraquat is a best example where you see a patient slowly deteriorates and mostly they don't improve after day 4, day 5, day 6.
Correct.
That is why it is very important in emergency room. The course of the disease should be very well educated, or it should be informed to the attenders that the first 3 to 4 days patient will be almost looking like normal. Then only patients get worsening or a patient becomes sick. So
Yeah.
that part should be very clearly educated to the patient attenders. Apart from Paraquat, uh, probably sometimes aluminum phosphide, but
Correct.
it
Aluminum
first 20.
phosphate functioning.
Yeah. But at time of presentation, sometimes I have seen the first 24 hours also. Patient is absolutely normal, and then
Yeah.
slowly starts deteriorating. And the difference here is once it starts deteriorating, it will deteriorate very, very fast, very quickly.
Yeah.
We see 80, 60 BP, then in no time you see BP is not recordable. You have to act very fast. Whereas Paraquat, it takes its own time. It's slowly. Even
Yeah.
it takes its own time. Yeah, but one more poisoning apart from Paraquat, it is aluminum phosphide, where we have to make sure that he may deteriorate in near future.
Yeah. Any other poisoning from Dr. Sendil or Dr. Manisundar?
Uh, Dr. Sendil is not available, I think so, sir.
I think somebody is joining with the Moto G71. I don't know, it's the same. Sendil Kumar was there. He has left at the time of initiation of the discussion on the Paraquat. Somebody else is there. Manisundar, would you like to make any comment?
No, sir. Yeah, the latest update is within 4 hours of Paraquat consumption. The latest studies says they can be started on ECMO.
Yeah.
Though
correct.
patient is stable, it's better they can be started on ECMO so that the outcome will be better.
Now, any other possibility of the similar behavior of the clinical picture of the kerosene poisoning can we expect? Like the lung injury, development of lung injury in a slow pace, the initial 24 hours, 48 hours later, they can develop. Is there a possibility?
The corrosive poison has a like a little similar to Paraquat is like even Paraquat affects mucosa. So it causes blood vomiting, and also it causes oral cavity ulcers. In that part, both Paraquat and corrosive poisoning is a little similar.
Kerosene poisoning.
Kerosene and okay. Kerosene, you're saying, sir. Okay,
Yeah,
fine.
kerosene poisoning can happen with the lung injuries at a later date. Is there any possibilities? I'm just asking you an open question.
Okay.
I'm not saying with the prefixed answers.
Yeah, kerosene poisoning definitely it causes chemical pneumonitis.
Yeah.
Again, it takes 24 to 48 hours to
Correct.
get a picture of small pneumonitis also. It takes more than 24 to 48 hours. So you have to keep in observation. You have to look for the clinical symptoms of any respiratory effect, and it needs to take repeated chest X-rays. Once you see changes in the chest X-ray, or probably CT chest also required. Yes, sir. Regarding kerosene poisoning, yes. Definitely, yes. It takes little time, and then chemical pneumonitis is coming up. Yes, sir.
Yeah, because GA symptoms happen immediately, but lung injury can happen after 24 hours to 48 hours. Because few of the poisonings, the postgraduate should be a bit alert that you anticipate the problem. At the same time, the other important part of treatment of any emergency department and ICU and our intensive care or SDU is going to be communication with the family members. So you have to take this as an important learning point. You're supposed to anticipate the problem, but clear about theoretical possibilities and talk to the patient side regarding the communicating clearly that possibility of anticipated future problem. Because as Dr. Sadish was mentioning about aluminum phosphate poisoning can cause sudden acute liver injuries also. It's a very, very important thing to have to keep in mind. Okay. And any other insecticide that can produce similar behavior. I'm not able to get the chemical name, but one more chemical is known for this late reaction. Not able to recollect, sorry. No, it's okay. Any other points to discuss? Anything else you want to add, Satish or Manichandar?
Just want to conclude that regarding Paraquat poisoning, more recent studies showing that within 4 hours of admission, if it is taken minimal or moderate quantity, it is better to go for charcoal hemoperfusion. And it is not only charcoal hemoperfusion for day 1 or 2, it has to be done continuously for 5 days.
Okay.
So this along with methylprednisolone infusion, this two combination becomes helpful in eliminating the poisoning, and also it is helpful in preventing pulmonary fibrosis. As for and rest of the treatments are supportive treatments like N-acetylcysteine or any other thing, antioxidant, all those things are supportive treatment. ABC and charcoal hemoperfusion and steroid are showing even this also having, with this also there is a good amount of mortality is there, but on later stages this initiating hemodialysis, charcoal hemoperfusion becomes a hallmark of the treatment. Yes, sir.
Dr. Manichandar?
Yes, sir. Most of the things are covered.
Covered. And Dr. Velammal?
Nothing, sir. Thank you, sir.
Yeah, I think if there's no further points to discuss, I think I come to the end of this today's discussion on these two important common problems like snake bite as well as the paraquat poisoning. I think the postgraduate might have been benefited out of this discussion, very lengthy discussion, especially from Dr. Velammal, Associate Professor from Medicine Department, and Dr. Manichandar, the consultant from Emergency Department, PSG, and Dr. Sadish, who is interested in teaching from the SMF Hospital, Annur. And definitely, I should thank personally both Manichandar and Sadish Babu, as well as Sendil Kumaran. Sendil Kumaran, actually, he was giving another talk, probably might have gone for this talk. He said he's having another commitment in Coimbatore now. So probably might have disconnected because of that commitment. Really, I should appreciate him for interest in this teaching program. And I think appreciate Dr. Shiba for presentation as well as wonderful discussion. Probably a few areas where you are supposed to improve. I think Shiba might have got the points to areas to note and improve from this point of learning process. And thank every one of you for joining and getting benefit out of this discussion. And thank you all the faculties as well as Dr. Shiba for wonderful opportunity. Thank you every one of you and good night all of you.
Thank you, sir.
Thank you, sir.